Chapter 7, Microscopic. For microscopic evaluation, these are some objectives that you should have as a takeaway. Here are some key terms. You've seen all 4 of them before in other classes, but go back and refresh your terminology so that you'll understand what I mean when I'm going through all of these slides. When you analyze urine sediment, what you're doing is the purpose of the microscopic is going to be to detect and to identify insoluble materials that are present in the urine. So there's certain specimen requirements that you'll have to have when it comes to the type of urine, the volume of urine. You need to make sure you have about usually 10 milliliters of sample to begin with. You'll see our COVID tubes that I talk about and how much they hold. They'll hold that much, but that's a good volume that we want to have. You have normal sediment. That should only have whatever is in the urine. If you have a contaminated specimen, then you could have sediment within the urine that would make it unacceptable, contaminated, and need to be recollected. There's a certain technique that you use to examine urine, and we'll go through that, not just in this PowerPoint, but also in lab. With specimen preparation, you have to make sure it's a concentrated specimen, and we do this by spinning the sample down, and then we take off the supername, which is also probably a term you need to go back and look up, and then just have the sediment that's left in the bottom. You still have to have a little bit of urine left in there. It's not like a solid bullet when you're done with it, so we have to make sure we have the correct concentration. So another reason that volume is important, because if you have too short of a sample, then your concentration is not going to be very good for you to look at these elements. There's a standardization for collecting and for processing. Like I said, we kind of talked about spinning it down. There's a system called COVO system, and these are specific tubes that we'll use for pouring off our sample into and then spinning it down. They have these little like pipettes that are standardized that come with them too. And so we'll look at that system. That's what we'll actually use in lab also. And this is the COVO system. So anytime we've talked about already about physical analysis of the urine, when we're looking at color and clarity, you're taking that original specimen and you're pouring it into these COVO tubes. You can use another type of a clear tube if you have to, but this is pretty standardized, and this is what I've seen in a lab also to be used. So odds are you're going to get something like this when you go to work. So you're going to fill the tubes up and then do your physical analysis off of it first. Once you've done the physical analysis and the chemical analysis, okay, because that's going to be on your whole specimen without, it needs to be equal throughout, everything mixed up. So you'll do those 2 things first. Once you do that, you're going to centrifuge the specimen. And this is where we're going to get that concentrated sediment on the bottom. So we're decanting, which means we're going to pour off what's called this supername, and then your sediment's on the bottom. So you're pouring off that top half, all the liquid. And we're leaving about 1 milliliter in the bottom. So there's just a little bit of urine in the bottom that goes with that sediment. And you want to have that too so that you can kind of mix it up. If you had just a little bullet, you're not going to be able to pull anything out. It's going to be a dry sample, and you're not going to be able to load it to look at it under the scope. So that's why we leave just a little bit of urine left in there. We mix it up real good to make it, to mix all the specimens up so we don't have stuff that's stuck on the bottom and then wasn't maybe on the top part of it. So we're mixing up really well again. And then we're loading it into the chamber. The chamber is in this last picture over here. It talks about loading it in the chamber. Now this specimen right here that they're loading in, they've added some type of a dye or a stain for it for visualization, but we don't use that. We're going to look at our specimen with no stain, and that makes it a little more difficult when we try to identify what's in the sediment, but you'll get used to it. Everything looks a little bit different when you start, and it can be very difficult, but after a while you'll start realizing what it is you're looking at and then be able to identify it. So they each have their little chambers, and you can kind of see where they're loading. So each of your slides, it's kind of what they are, it's a slide, has individual little chambers, and you'll fill them up. And this is why I said it's nice to have the standard system, because if you'll see, they've got this little bulb on the end. That bulb is good, this type of pipette, for loading into the chamber. It makes it easier. We'll probably, if we don't have a whole lot of these, then we'll probably use regular pipettes, which is fine too, but these come as a set. So we're analyzing them under the scope. Depending on what you're looking for will depend on the power of field that you're using. We will never use an oil immersion for these, okay? Everything should be big enough that you can see it. Remember, we only use, like the 100 oil is good for IDing your bacteria. We can use the high power to see bacteria. We don't have to identify it. We just have to say that it's there. But when we start out, you're going to want to adjust your light and make it kind of lower, not as bright. It's going to be easier to identify cells that way. You'll start on the low power field to look for casts, the epithelial cells, and things like mucus. These are really large, so you should be able to identify them easily. That's why we look for them on low power field. When you go to high power field, you'll look for the smaller elements like white blood cells, red blood cells, crystals, bacteria, yeast, sperm, and parasites. Parasites are something you're not going to see in class, and probably not a whole lot of anywhere either, but you'll definitely see the other ones regularly. And we'll learn how to identify all of them. That's the point of this presentation. There's 3 different types of epithelial cells. You've got squamous, transitional, renal tubular. We say renal tubular, we'll abbreviate it as RTEs. And you may hear me say epis instead of epithelial cells. That's what I'm talking about if I say epis. Oh, this cut off. I'm sorry. Sometimes I hate how it does this. Okay, these are your squamous epithelial cells. These are your most common. They're what you're going to see usually. And they're the largest type of epi. They're about 40 to 60 micrometers long, or round most of the time. They're going to be that round shape. They kind of look like a fried egg. They have that nice nucleus here in the middle. So here's your little nucleus. And then kind of the little fried egg edges. See what I mean? So they kind of look like fried eggs. It's the best way to explain them. And they have this large irregular cytoplasma. The edges can kind of curl or fold. So this one over here is kind of folded. They can also clump up kind of on top of each other. If you have a large number of them, it typically will indicate some type of contamination. Now, when we talked about different types of collection methods, which ones were preferable for different types of tests, remember that if you use the clean catch, the midstream clean catch, that's one that you want for your microbiology specimens for trying to do a culture. So if a patient were to collect it incorrectly, then you would see a lot of epithelial cells, and this is a contaminated specimen. So it's really important to educate your patients on the type of collection that they need in order to reduce that. This also comes with, you can let the nurse know, because you're not always going to have any patient interaction. So that's something else that can come from the nurse. This is normal. Like I said, a lot of times it's from contamination. So it's not significant. It's just kind of an external contaminant. It's not a bad thing that it's there. Okay, I don't want you to think it's a bad thing. It's there. And you'll see it in pretty well every type of urine that we do. These are clue cells. All they are is they're the squamous epithelial cells, and typically they have bacteria that are here adhering to them. They look kind of hairy. So you'll see how the little, looks like little particles or whatever, they make it kind of hairy. Whereas when you went back and you looked at, not the renal tubular, sorry, when you looked at these, they're pretty smooth. Here on the bottom, it's kind of smooth, whereas this clue cell over here is kind of jaggedy, it's hairy. And these are typically seen in a vaginal infection as a contaminant. transitional epithelial cells. These are about 20 to 40 micrometers large. They are variable in their shape. They can be spherical, polyhedral, caudate, which means they have a tail. But so this is a good picture over here, kind of not as a stained one, but here they're very round. Sometimes we'll talk about the renal epithelial in a minute too, and so they kind of can be confused with that. So you need to pay attention to what you're calling. This one right here is not as round. If you'll notice too, I didn't say anything when we talked about these, but when you go back and you look, sorry, I don't mean to bounce around, but the nucleus is almost the same size as this is a white blood cell. Let me get a different color. This is your red blood cell. Or not red, I'm sorry. This is your white blood cell. It's almost the same size as this nucleus. So it's kind of the same way here. You can look that here's your white blood cell and here's your nucleus. Okay. So when we start talking about white blood cells, that's something to kind of help you too. So these have very firm edges. You can kind of see that they have, let me change my color again. You can kind of see right here, it looks like it's got a thicker edge around it. So they have firm edges where these other ones were not so firm. See how they're very light? They're located in multiple areas of the tubules. So these can actually appear as sheets, which is kind of an overlapping thing, kind of like this, but there'd be more of them. That would be considered a sheet, or groups. And if you have a lot of that, that can be caused by an invasive catheterization. They're also present a lot in UTIs and in transitional cell carcinomas. Renal tubular epithelial cells. Now with these, this is a very good picture of what they look like to me. Well, this is kind of what they're going to look like more under the scope, but this one right here shows you a really good representation of what they're going to look like. They're located in numbers of locations throughout the renal anatomy. Sorry. They have smooth cytoplasm. They kind of resemble casts sometimes because they're so clumped up. And we'll look at casts in a minute. They can be variable shape, but typically they're going to be round. And they have a very dense nucleus. So you can kind of see, looking at it, like I said, these right here are a little difficult, but see how you can see this nucleus very well. And that's because they're very dense, and they'll take up about 2/3 of the cell. So they're a lot larger. So you don't confuse them. The transitional, theirs aren't as dark or as dense. So if these were round, that can help you to differentiate between those and renal tubular. Now, you have to be really careful about calling renal tubular epithelial cells because these are very significant. So always make sure that's what they are. You can always have somebody look behind you. They're pathogenic, and they can be seen in a lot of like renal tubular necrosis. So these are very clinically significant. The other ones, not so much. But this one, these are clinically significant. This is a good picture that kind of shows you a little bit about a little of everything. So I think that's a good one to look at for some comparison also. So you've got the squamous epithelial, which are really large. You have a renal tubular epithelial. And if you'll notice, this one and this white blood cell can look very similar, but this one with the white blood cell is a whole lot smaller. So kind of looking at size even will help you with that. You can also still see this nucleus in the middle. Your transitional, it kind of has that tail with it, so it's not exactly round, so you can kind of tell the difference between this and your RTE. It's got the little tail. And your red blood cell, it has no nucleus, right? And if you were to compare it to this white blood cell, you can see all the granulation within the white blood cells, whereas the red is smooth. There's also some crystals on here, like this one's a crystal, but we haven't talked about those yet. These are some other elements that you might see. And this is mostly when I'm still talking about low power field, right? Because we're talking about epithelial cells. So this is still on low. So still on low, you can kind of sometimes see these. This oval fat body over here, this is a little more difficult probably to ID. Bacterial, when we start looking at like amorphous crystals, sometimes you can have a problem with that. But if you look real carefully, you can kind of see they have that like rod shape. Your mucus, it just kind of looks like threads. Same thing with your fiber. Fiber is a little more solid, whereas these are a little almost clear with little dots, right? So they look a little different. Your starch just looks kind of weird. And you'll notice there's another one called a glitter cell that we'll talk about soon too, and they kind of, I think, look a little similar, but once you see starch, you'll always be able to identify it. It looks like a funny looking red blood cell. And fecal material that's in here, it just looks like a blob. That's not something you'll have to call. You would have to call things like bacteria. But other than the bacteria, you're not really going to call these other ones typically. You can note, like if we saw them in lab, you can note it on your paper that they're there, but bacteria is the only thing that pretty much can be something significant. And these other ones are just things that made it into the urine, some type of a contaminant. Casts are also seen on low power field. You may have to adjust your light. Like I said, you want it to be a darker field, so you want less light usually. So sometimes with casts, you have to adjust it a little bit. But these are cylindrical bodies, typically in the distal convoluted tubule. It says there's also in the convoluted in the lumen, but we're going with DCT, okay? So know that they're formed there because that's where the majority of them are going to be. They are a matrix that's formed from uromodulin glycoprotein. So this is not an albumin, okay? Tam horseful protein is not an albumin, so that's one that we talk about. It's actually a normal lubrication secreted by our renal tubular epithelial cells in the ascending loop of Henle and in the DCTs. These parallel sides with a round or broken end, this one right here, this in bold, that's the biggest thing that you have to remember when we start looking about casts. So if you're not sure what something is, or if you have like a lot of cells that are kind of clumped up, you may mistake them for being a cast. But your casts are always having parallel sides, and they have typically a round or a broken end. And you'll see what we talk about on those, depending on which type you have, will depend if it's round or broken. And that'll help you too with identification, usually. They're formed elements, and typically they're going to contain some type of an inclusion. Based on what type of an inclusion you have, which is whatever's inside of them, that helps you to identify which type of cast. And so that's how they're identified. Not all casts are significant. So some of them are normal, like your haline and your finely granular. But some of them are, and those that are significant are going to indicate renal stasis and diseases. And then the number of casts, when it comes to irregular ones, are going to reflect the severity of a disease. With your casts, they can break down over time. So when you have an older urine specimen, you may not see them. They've already broken down. So it's important to have a fresh specimen for any of the testing. But it's good for you to know that's another thing that's affected by time. And refrigerating it's not really going to help either. So they're just going to go away. Your Haline casts are pretty colorless and pale. Most of them are colorless and pale, but that because they are, it makes it a little bit difficult sometimes to actually see them. You can also get an increase in casts if you do a lot of strenuous exercises, but people who do a lot of strenuous exercise within like a day or two, if they haven't been exercising like that, then their casts are going to go away. So they're not clinically significant. That's just some people who do strenuous exercises, a lot of their stuff looks like it would be abnormal, but it's really not, especially like protein too. So these are haline casts. These are round on the end. So this one right here that says not haline, notice it's got blunt edges. So that's not a haline cast. These all have the rounded edges, and they're very clear. See how, like on this one, this would be kind of difficult to see. There are all cylinders with the rounded edges. Okay. And these are seen in a lot of urines. Now your granular, you can have a finely granular or a coarse granular. So it just depends on how much is in there, how many granules. The more granules you have, the darker it looks. So these actually aren't colorless. They'll have more color to them. And that's because of hemoglobin. So the hemoglobin in them kind of makes it look like it has a little bit of a stain. These are bacterial casts. If you have a bacterial cast, most of the time it's going to be mixed with white blood cells, or it can be. They look a lot like granular casts, but you also can see all this other stuff on outside. You see some bacteria. You're not normally going to see like a bacterial clump. So if you see a bacterial cast, like I said, it kind of is going to look like a granular one, but there's none of that color to it. Like when we're looking at the granular one, see how there's more color. Your bacterial one's not going to look like that. These are white blood cell casts. They can be seen in a disease called pyelonephritis. You have to be able to differentiate between clumps and a cast. Sometimes you'll see white blood cells that are kind of gathered together, but to know that it's a cast, remember they're kind of in a cylinder shape, right? And they have those round edges. So make sure it's in this shape and it's round. And some of them, like this one, see it's not all clumped up. You can still see the cast formation really well, and it doesn't have as many white blood cells, but this other one is packed with white blood cells. So you'd have to make sure that wasn't like a clump that you're calling. Make sure it's in the correct shape. These are red blood cell casts. They're found in a disease called glomerulonephritis. These types of casts, they have a high hemoglobin in them, which can give them that color. And if they're seen in a urine, typically it's kind of indicative of a patient who has bleeding from the nephron. If you look back at these white blood cell casts, you can tell these are white blood cells. You can see the granules in them. Whereas if you look at these red blood cells, they're a lot rounder. They don't have that type of granulation in them. Especially that one's a good one to look at. You can tell those are red blood cells. They're completely round. There's no central pallor to them. They have the same, it's the same as like if you looked at a blood smear, except it's not stained. They look exactly the same, just with no color. When you have a renal tubular cast, this can be due to advanced damage. These are with your renal tubular epithelial cells. It looks very similar to a white blood cell cast. This one over here, they're much larger, and you can look at the large nucleus and then the dense edge of it. So these, with this bigger one, you can really tell those are renal tubular epithelial cells as opposed to white blood cells. This one over here might be a little trickier, but it's definitely a cast formation. You would look throughout the rest of the urine when you're scanning the fields. Don't ever just look at something that's a cast and be like, oh, well, it looks like this. Okay, well, does it make sense with what's going on with your chemstrap? Does it make sense with what else you're seeing in all the other fields? So that's helpful too. So pay attention to what else is throughout the urine, not just don't just guess. Waxy casts, they look like blocked edges. So they kind of look like a piece of wax, I think. So they're very straight, blunt edges. This one over here is kind of got some little pieces torn out of it, but a lot of times this is what they look like. This fatty cast, they're refractile. They don't look like red blood cells. They look funny. Remember, sometimes things look a little wacky, for lack of a better term. And they kind of have a shine to them. I'm not sure how long I've been going, but I'm going to go ahead and take a stop since we've talked about what we look at in the low power field, and then I'll talk about the high power field in just a minute. That way